Radhika ma'am, please start.
Yes, yes. Good evening, esteemed faculty and all the delegates. So let us start the yet another session of Blossom webinar. So I invite Dr. Kalpana madam to give the welcome address. Dr. Kalpana ma'am is a Foxy Infertility Committee chairperson, joint academic secretary of TAPISAR, founder secretary Madurai chapter of TAPISAR in 2020, co-chairperson of Infertility Committee TNFOG, past vice president of MOGS, organizing secretary of Madurai Obs and Gynae Society Silver Jubilee Conference in 2018, MOGS Annual Conference 2022 and 23, South Zone Vice President Conference 2023 and Mid-Year Conference of TAPISA in 2026. She is also a member of Institutional Ethics and Principal Investigator in Clinical Trials. She is a course director for postdoctoral fellowship in endogynecology affiliated to MGR Medical University. She has won many awards. Best Doctor Award by Dr. MGR Medical University, Golden Excellence International Award by European Continental University, Medical Excellence Award in 2018 from Governor of Tamil Nadu, Best Medical Service Award from Madurai District Collector, Best Committee TNFOG Award from Health Minister Tamil Nadu 2022, Nana Anemia Foxy Achiever Award 2023, Foxy Badlav Appreciation Award 2023, ISAR Rising Star Award 2023, and she also received Legend of Gynecology Award from Foxy President, and she received Foxy UNICEF Appreciation Award in 2024. She's got a wonderful CV. I request Dr. Kalpana ma'am to give the welcome address to all our respected faculty and our respected delegates.
Hello. Hi, ma'am.
Thank you, Dr. Radhika, for the wonderful introduction. It is my honor to welcome you all for this Blossom webinar, which had been successful over the past few months. And the name of Blossom had been selected aptly for this reproductive medicine webinar because it
Hello?
represents the
Hello, ma'am, I'm joined.
flowering technical team. Can you please mute others so that
Sure, ma'am. Sure.
so it represents the flowering part of a plant which becomes a fruit. So in that aspect, the name had been selected and it had been successful over the past few months. And it is our great honor to have Dr. Jayesh Amin, President of ARGI, as our chief guest, and Dr. Sampath Kumari Madam, who will be joining little late. And also we have selected wonderful topics, ovulation induction, even though it is really a common topic. Recent advances will also be discussed in this webinar by Dr. Indu, Dr. Kriti, who will be moderating this panel. And we also have experts for this panel, Dr. Mani Mukta, Dr. Shalini, Dr. Sadhana, Dr. Swarupa, Dr. Kushbu, Dr. Vandana. And we also have embryology knowledge is essential for a clinician also. So we have an interesting topic, set up an ART lab, which is the need of the hour for expansion from level 1 to level 2. Dr. Atita, Dr. Akash will be moderating this panel, and we have expert Dr. Rahul for his expert views, and we also have Dr. Sankeet, Dr. Sanjay, Dr. Dayanidhi, Dr. Ram Prakash, Dr. Falguni, Dr. Parag, who will be sharing their expert knowledge in this panel. And so once again, I welcome you all. Once the lamp lighting is over, we will have our chief guest address.
Lamp lighting.
So it is our honor to welcome our chief guest, Dr. Jayesh Amin, Clinical Director, HOD, National Strategy Developer of NOVA, and also President Association of Reproductive Genetics and Immunology, Chair elect ASRM Ovarian Insufficiency SIG. So he's also into IFS, National Advisor, Organizing Chairman of Fertivision 2024, East Additional Joint Secretary, past convener of Fertility Preservation Society, also past secretary of Gujarat IFS chapter, and he has got a great academic achievement, authored many books, trained 200 plus gynecologists, and also received Excellence in IVF Treatment Award from Government of India in 2016. Gold Award, Excellence in Reproductive Endocrinology in 2024. Welcome, Dr. Jayesh, for your words of wisdom for this webinar.
So, good evening to all senior the faculties and Dr. Kalpana Madam and a lot of other doctors, those who are involved in this creating a knowledge creating series. When I'm talking about ovarian stimulation, and if you ask me today also that even you go anywhere in the across the world, and if you see the any workshop ovarian stimulation, there will be a maximum people are there. So we all people like this ovarian stimulation very much. And we always learn something new thing. I think so some tips that we can get in each and every, and then we can implement in our clinical practice. And this is also so much important because we sometimes those who are really become experienced people in the fertility, but there are a lot of young generations are still waiting for a knowledge that they require knowledge to how to stimulate and how to know the basics of the endocrinology and stimulation. And I think so for that, I think so this type of webinar is really neat for today's time where IVF is really at the peak in the industry as well as in the India country. I think so a lot of centers and a lot of new buddies will definitely become a fertility specialist, and where they need a basics of IVF, and which is called reproductive endocrinology, where ovarian stimulations is the basic everybody wants to learn from ovarian stimulation. And I think so there are so many novel things are now coming in ovarian stimulation also, where because of lack of number of the patients, certain people do require certain sharing of experience by the different consultant. Those might do have a more work and they use the novel protocol and they can share their views and ideas. So I think so this type of things will definitely not only help the new generations, but also for rectifying their knowledge, and it is so important. And I will definitely congratulate the organizing team as well as the people, those who are involved behind this whole webinar series. Must congratulate and keep doing all these things because we should. There are some group of the people, those who are going to do all these things, and then the other new buddies will get more knowledge and India will get more optimized in IVF practice. And thank you so much for calling me on this type of, because I'm going to be listen this all this I'm to at up to the end, that how what exactly new things that we can come to know. And definitely I will share my views if required at the end of the day. Thank you so much for inviting me as a chief guest. Thank you.
Thank you, Dr. Jayesh, for your words of wisdom. Exactly, ovulation induction is a good old topic, but novel therapy had to be discussed because we need to update our knowledge about newer stimulation, newer drugs available, newer investigation to get best embryo out of our lab. So let us listen our experts of this webinar.
Okay.
Radhika?
Nice, ma'am. Thank you, Kalpana madam. Thank you, Dr. Jayesh sir. So let's move on to the first topic, panel discussion, ovulation induction. We have the speaker, Dr. Indu madam, Dr. Indu Chauhan and Dr. Kriti Prasad. Dr. Indu Chauhan is a clinical director, Vardhan Maternity and IVF Center, Jamshedpur, Jharkhand. And she is an MBBS and she's done her MS in 1988 from JLN Medical College, Ajmer, University of Rajasthan, Jaipur. And she's affiliated to IMA, FOXY, ISIR, and ISOPAR. She's a member of FOXY Perinatology Committee 2017 and member of FOXY Adolescent Health Committee in 2023, secretary from Jamshedpur Obs and Gynae Society, and president of Jamshedpur Society in 2016 to 18, chairperson of ISIR Jharkhand chapter, and presented papers in local, state, national, and international conferences. She is also the organizing chairperson for local and state level conferences. And then we welcome Dr. Kirti Prasad, who is a gynecologist and an IVF specialist from Ranchi. And she's been very experienced for the past 16 years. And she is an IVF consultant at Seeds of Innocence Ranchi. And she's a member of FOXY, ISAR, and IFS. And she's practicing IVF for 10 years at various organizations. Welcome, Dr. Kirti Prasad.
Thank you, ma'am.
So we have the panelists, and I request Dr. Indu Chauhan ma'am and Kriti Prasad ma'am to introduce the panelists.
Good evening, organizing
ma'am.
persons, Dr. Kalpana, Dr. Radhika, and our chief guest, Dr. Jayashami. As Dr. Jayashami told, that this ovulation induction is a very, very important topic as far as infertility practice is concerned. And we have kept this panel very basic, not for the IVF specialist, because I thought this is for a general gynecologist. And let me introduce my panelist, Dr. Mani Mukta. She is President Secretary of ISAR Jharkhand chapter. She is organizing committee member of EZONE Yuva FOXY, member of FOXY, IFS, ISAR, ISOPAR, all published paper in various national and international journals, and she has presented paper in various conferences. She is director at Janya Hospital and IVF Center, Ranchi. Dr. Kriti, you introduce the other panelists, please.
Sure, ma'am. I welcome Dr. Shalini Varman. She is consultant obs gynae in Tata Main Hospital and Manipal Tata Medical College. She's from Jamshedpur, and she's a reputed gynecologist in Tata. She's also contributed as a chief editor in various kinds of books, and her field of interest is basically in the final year postgraduate teaching and medical legal aspects of obs gynae.
Good evening, Dr. Kirti, Dr. Indu, and all the respected chairpersons.
Hi, Dr. Shalini. Welcome to the panel.
Thank you.
Then I would like to introduce Dr. Sadhna, who's an MBBS MS Obs Gynae, and she is the director of Sadhna Hospital, Dhanbad. She's been a former secretary in Dhanbad Obs and Gynae Society, and she has presented many papers in Yuva FOXY and All India FOXY conferences. And she's presently working as a director in Sadhna Hospital, Dhanbad. Welcome, Dr. Sadhna. Dr. Sadhna, are you there?
Dr. Sadhna.
Yes, good evening. Good evening.
Welcome, Dr. Sadhna.
Yes, thank you, ma'am, and good evening to all of you.
Okay, so our next panelist is Dr. Swarupa. She's an MBBS MS in Obs Gynae, and she's the director of Amrit Hospital and IVF Center, Ranchi. She's also a laparoscopic surgeon, and she's practicing as a famous IVF specialist over here. And her areas of expertise is predominantly into infertility, and she's also a member of ISAR, IFS, and FOXY. She has been awarded as Mrs. Chandravati Devi Jagannath Singh Prize through FOXY. So, welcome, Dr. Swarupa. Dr. Swarupa, are you
Thank
there?
you, Dr. Good evening, Dr. Kriti.
Good evening, Dr.
Thank you for
Swarupa.
introducing me. I am here with you.
Yeah. Okay. So our next panelist is Dr. Khushbu. She is MBBS MS Gynae, and she's done a fellowship from Milan Fertility Center, Bangalore. She has almost 10 years of experience over here, and she's also published articles in the European Journal of Obs Gynae and Reproductive Biology. Presently, she's working as a consultant and IVF specialist at Surya Super Speciality Hospital, Jharkhand. So, welcome, Dr. Khushbu, in the panel. Are you there?
Yeah, thank you. Thank you for the introduction. Thank you. I'm here.
Okay. So, our next panelist is Dr. Vandana. She is an MBBS DGO, and she is already practicing IVF. She's already there as an IVF consultant at Indira IVF Jamshedpur. She has done her MBBS in DGO, and she has professional experience as a senior consultant in Indira IVF for the past, I think, for how long, Dr. Vandana?
Good evening to all seniors. For last 9 years, I'm practicing at Indira
Okay.
IVF Jamshedpur.
Okay. So, and you're also a member of SR, Foxy, and IFS. So, welcome, Dr. Vandana, in the panel.
Thank you. Thank you.
So welcome all the panelists.
Thank you, ma'am.
Good evening, ma'am.
Are you able to see my screen?
Not yet, ma'am.
Oh, ma'am.
Yes or no?
No,
No,
no.
ma'am.
No. Are you able to see now?
No, ma'am.
No,
What's the
ma'am.
problem?
Ma'am, at first open the PPT, ma'am, and
Yeah,
then
yeah, I've already opened the PPT. It's already
and then
open.
come to Zoom and click on share option.
Yeah, that's what I did. But I don't know why I'm not
And
able
at the end, after selecting the tab, you need to click on share again, ma'am.
अभी तो किया था ना मैम आपने कुछ
हाँ
समय
हाँ
पहले
अभी तो किया था हाँ
See it in the beginning, actually.
yeah.
Can you see the share option in Zoom, ma'am?
Yeah, I am able to see and I shared also. But now I'm not able to share it. PPT is opened. I can see the share option also.
Yes, ma'am.
Entire
Please click
screen.
on it. Yeah,
Yes,
entire screen.
yes, entire screen. But
And then
why
click on
this?
share option, ma'am. Blue color.
Yeah, the
option.
share option is not coming. It is coming cancel.
Oh,
Maybe you can close and
Yeah, yeah. Now, are you able to see?
yes, ma'am.
Yes.
हाँ जी मैम अब दिख रहा है
Yes.
So good evening, everyone.
Perfect, ma'am. Perfect.
Yeah. So to begin with, let's just Dr. Amin has already told that ovulation induction is very, very important as far as any treatment regarding infertility is concerned. So before we start talking about ovulation induction, what are the goals of ovulation induction, Dr. Shalini? Can you explain us?
Yes, ma'am. First of all, ये है कि what is ovulation induction? So ovulation induction is a process in which we give medicines which help in the formation of the ovum, which is the dominant follicle, and finally it ruptures. So that should be our basic aim. So first of all, in what patients do we actually give ovulation induction? It is in those patients who do not ovulate. So loss of ovulation may be basically in, there are many categories of loss of ovulation like WHO 1, 2, 3. WHO defines ovulatory disorders these ways. So basically used in all patients in which we want to produce the ovum and the dominant follicle. That is the main goal of ovulation induction, more so in patients of PCOS, which is the most common thing we entertain. Secondly, since we know that ovulation induction, ovulation disorders is of many types, type 1, type 2, type 3. So the type 1 disorders है, उसके अंदर there is a problem in the uterus also. The endometrium is not very good receptive. So our main second aim is to to optimize the endometrial development, which basically occurs in estrogen deficiencies. So we give such medicines which even which cause the formation of the ova, as well as they optimize the endometrial development. Thirdly, the main reason for ovulation induction is that we can tell the patient when she is likely to ovulate. Hence, we can time the intercourse in such patients. That is a very important indication, timing, exact timing of ovulation by giving medicines. Then fourthly, when we give ovulation induction, we are also keeping a track on the number of follicles which develop. So once we see the number of follicles are more than 2 follicles of 16 mm or more than 3 follicles of 14 mm, we can minimize the risk of a multiple pregnancy by avoiding a multifollicular development. So these are basically the goals of ovulation induction. And once we avoid a multifollicular development, we are also decreasing the risk of OHSS, which is ovarian hyperstimulation syndrome. So these would be the most important goals of ovulation induction.
Very
Yes, ma'am.
rightly said. Yeah, very rightly said, Dr. Shalini, that you have explained it very nicely. That is, we want to restore ovulation in ovulatory patients, whatever is the type of anovulation. Accordingly, we formulate or we design our treatment, optimize endometrial development to say correct timing of intercourse and minimize the risk of multiple pregnancy as well as OHSS. So maximize beneficial effects of the treatment, strict cycle cancellation criteria, avoid OHSS and multiple pregnancy. So you have already told that what are the initial starting point of ovarian stimulation. It is anovulation, so to restore the normal ovulation. But in cases of IVF, we want controlled ovarian hyperstimulation. So these patients are actually normally ovulating, but here we want multiple follicles so that we can have multiple optimum number of oocytes so that we can produce optimum number of embryos. So our ovulation induction depends upon what is our aim of ovulation stimulation, whether we want a single monofollicular development for the normal timed intercourse or IUI, or whether we want ovulation induction for the IVF. So now, Dr. Kriti, will you read out the first case?
Sure, ma'am. I'll be presenting with the first case. So we have a couple who's trying to conceive for more than 1 year. The female being 28 years, male partner being 32 years. Her the male semen parameters are normal. Menstrual cycles are regular. AMH levels are normal. Now, in such cases, how to proceed with such a case in terms of deciding for the ovulation induction? So, and what are the factors to be kept in mind before starting ovulation induction? So, I'll ask Dr. Mani Mukta.
Yeah. As described in the case that the couple is trying to conceive for last 1 year, so we can proceed with the ovulation induction in this case. And before proceeding for ovulation induction, we must keep in mind the three most important factors. First is the age. Age here is 28 years. That is she is not very old age group patient. And the second factor is BMI, which is not given here, because BMI is a very, very deciding factor for doses of ovulation induction. And the third factor is we have to see whether their ovarian reserve is adequate or not by antral follicular count on transvaginal sonography or by doing blood test serum AMH. And by correlating with these, we can just find out their ovarian reserve. And apart from this, we must rule out other factors which can affect ovary and uterus. Like in ovary, there is on baseline scan, on day 3 scan, there is no any cyst or endometrioma type problem. In the uterus, the uterus may not, there may not be any polyps or any septum or anything else. And tubes must be patent. But some of the clinician may not go for tubal analysis for first 1 or 2 cycle, but I prefer to do it. And there is a semen parameter is normal. So we find out all these things, and then we will proceed for the ovulation induction.
Sure. Obviously, now since the female and the male both have just tried for 1 year, so it stands as they are fresh cycles, fresh for ovulation inductions, and not much investigation need not be done in such cases. Baseline ovarian reserve should be considered, age of the patient, obviously the BMI of the patient. As Dr. Mani, as you've rightly said, HSG a tubal test needed or not to be needed in first 2 cycles is definitely consultant dependent, doctor dependent. And initially 1 or 2 cycles with such age group with less than 1 year fertility, so almost like 1 year fertility, we don't go for the HSG at once. Apart from that, prerequisites to be checked, as ma'am, you've rightly said. So definitely ovulation induction should be tried in such cases.
Very good, Dr. Kriti. So the bottom line is that we should be knowing what are the prerequisites before starting ovarian stimulation. So this is 1 year of infertility, young patient. So first thing is very, very important is that we should take a detailed history of the coital history. What kind of intercourse, what is this thing, frequency of intercourse in the couple. So the history is very important. And as far as we were discussing about tubal factors. So yes, it is very, very clinician dependent that few clinicians, they initially want to start do all investigation before going for ovulation induction. Whereas in my opinion also, initially 1 or 2, 3 cycles in young patients when the infertility is not very prolonged, and if she has come to the clinician for the first time, she has not gone anywhere else, we may give 2 or 3 cycles of ovulation induction and then go for tubal factor assessment. And the take-home message from this particular case is that we should be doing a baseline scan to know about the ovarian reserve so that we can see the AFC or any other remnant follicles are not there, there is not endometrioma, or if there is any polyps and all. So it's very important to do a baseline day 3 or day 2 transvaginal ultrasound before starting for ovulation induction. So next, we'll be going to in this particular case, what drugs would you like to choose and why? Dr. Manimukta, you please answer this question.
Yeah, as the patient is young and everything is fine, we can prefer the dose. The drug of choice is letrozole, and we can go with that because there is no any other history of previous stimulation or any other medication. We can go with 2.5 mg of letrozole from day 3 of the cycle for 5 days, and thereafter we do the follicular monitoring, and when the follicular size is adequate, we give the trigger dose, and thereafter we can tell them for natural cycles, timed intercourse or timed intercourse. I think it is preferable. If there is any other, if semen analysis were not normal, then we can proceed with IUI.
Very well said that, though theoretically we say that clomiphene citrate, but I think most of the clinicians are not stopped using clomiphene citrate. The drug, we start with letrozole, 2.5 to 5 milligram, depending upon the BMI. So it is mentioned that HMG and all, this is taken the next step of the treatment when the patient is unable to ovulate, and response of ovulation stimulation should be assessed by transvaginal sonography. Here, I would like to emphasize that all clinicians should be doing their transvaginal sonography by themselves, because there you can judge the effect of your own treatment very precisely. So this is the letrozole is the drug of treatment, and when there is a short term of infertility, first time the patient is being given ovulation induction. So we already discussed, is there any need of tubal assessment in such cases? Dr. Sadhana, again, you can emphasize what is your opinion about the tubal assessment in cases of short infertility.
We have already discussed all the points. I would like to sum up. Tubal patency ideally should be done, and usually most of us prefer to do tubal patency test. But in such type of cases, the patient is less than 30 years old. We can get entire clinical history, as you told earlier, coital history. Sometimes patients are working and they are not spending too much time with each other. So few cycles of clomiphene can be given. Clomiphene or letrozole ovulation induction can be tried. But if the history is suggestive of clomiphene resistance or any other risk factor like increased BMI or insulin resistance, we should go with tubal patency test. We should plan our treatment after doing tubal patency. Sometimes patients are not willing to do tubal patency. They like to go with ovulation induction. So we can go with the patient.
Very rightly said, Dr. Sadhana. Many times patients, they are not ready for this tubal patency test, especially HSG, because they have heard so much about it. It's a very painful procedure. So
Yes,
even if you
yes.
suggest them that you go for tubal patency test, they will request, oh no, ma'am, first you give us 2-3 cycle of trial and then we'll go, because it's a very painful procedure. So we have to take, our patient, the couple also in the confidence, and then decide about the future test and treatment. So rightly said, the tubal patency should be done when the patient is willing. Otherwise, we can give 2-3 cycles of ovulation induction. But if we plan IUI, or if we plan treatment with gonadotrophins in cases of CC resistance, or for any other reason, poor ovarian reserve or something like that, the tubal patency test should be done. That is the bottom line, that all these treatment should not be given without taking the tubal status into the consideration. So now the next case, Dr. Kriti, you please elaborate about the next case again. Dr. Kriti, are you there? Hello?
Hello.
Yeah,
Hello.
are you
Yes,
able
ma'am.
to hear me? Yeah.
Yes, ma'am. So case 2 is 26 years lady with primary infertility of 3 years duration. Her cycles are irregular, so that may last from 30 days to 3 months, suggestive of oligomenorrhea. Her BMI is 28. Her hormonal profile is FSH, which is 6.79, LH is 8.9, AMH is 6.8, HSG being normal. Ultrasound is suggestive of polycystic ovaries, semen analysis, normal parameters. So now I would like to ask Dr. Swarupa as to what is the case, how do you sum up the case, and what is the role of serum AMH in this diagnosis, and what is the effect physiologically it has on the ovulation of a PCOS female? Dr. Swarupa.
Yes, thank you, Dr. Priti. The patient is a known case of PCOS and her AMH level is high. As we know, as you already know, AMH is the hormone that's secreted from antral and preantral follicle. Both the antral follicles are very high in cases of PCOS. So AMH is very high, usually very high in cases of PCOS. Usually diagnosed PCOS have AMH more than 5. And AMH is not a diagnostic criteria, but it is one of the criteria for diagnosis of PMS. If AMH is high, this group of patients usually shows the poor responsiveness in FSH, endogenous FSH level. Thus, in this group of, particularly in this group of patient, we usually have CC failure. They are not good responders with clomiphene citrate. There is particularly clomiphene resistance is seen in that group of patient. So we have to plan our treatment modality in different way. Different drug, particularly letrozole, usually we prefer in that group of patient.
Okay, so yes, Dr. Swarupa, AMH is basically it's a prognostic factor. It shows it's basically to decide the stimulation response of a PCOS patient, because AMH definitely suggests not the almost small antral follicles and the resting follicles which are there. So definitely there's a response to failure can be seen in very high AMH patients. So the next question will be, which ovulation induction agent you prefer? Clomiphene citrate or letrozole in cases of anovulatory PCOS women, and why? As you said, I think letrozole, right?
In particularly this patient, BMI is not mentioned. If she is obese, definitely first I will ask her for some lifestyle modification like weight reduction and change her dietary habit and some strength training. Apart from that, when we suggest from ovulation induction, my first line of choice is letrozole, because it is an aromatase inhibitor. It has both central actions and peripheral actions. Centrally, it essentially it increases FSH secretions as it increases pulsatile secretion of gonadotropin releasing hormone, thus increase FSH secretion, and that FSH lead to follicular maturations. And second, in peripherally, aromatase inhibitor usually increases androgen level little bit, and that androgen also upregulate follicular sensitivity and follicular FSH receptors also. Both that way, it usually helps in follicular maturations. Initial dose is 2.5 starting from day 2 or day 3 of cycle for 5 days. If follicular growth is adequate, usually this group of patient, I do folliculometry, definitely go for folliculometry. Transvaginal ultrasonography is better. If follicular growth is adequate, that is day 8 or day 10 folliculometry shows that follicular size is more than 10 millimeter, then follicular growth is adequate. Serial folliculometry is advised. When the size is 18 to 20 mm, go for trigger. If follicular size is not adequate on day 10 or day 8 ultrasound, I will prefer to increase the dose by 2.5, that is 5 milligram for another 5 days.
True.
Correctly
So,
said, letrozole is the preferred drug in this case. And why it is preferred? Because it is the PCO patient and already is high LH. And when letrozole is used, it doesn't affect the LH level.
LH level.
Yeah, it is very, very important in this scenario, particularly where LH is already very high. So letrozole is the preferred drug in this case.
true. Thank you, Mani, Dr. Mani, for adding the important lines. So we'll go to the next question. So how to proceed in the PCOS women with clomiphene resistance?
First, we have
Dr.
to define what is CC resistance. In patients who are unable to ovulate with the dose of 150 milligram for 5 days for 3 to 5 consecutive cycles, then it can be defined as a CC resistant case. There can be many factors associated with CC resistance. The first is the obesity, that is high BMI level. Then there can be advanced age, hyperandrogenemia. These all prevent ovaries from responding to increased endogenous FSH levels after CC therapy. So the management is what everybody is telling. Letrozole will be the first line of management for those cases. Gonadotropins can be used as a second line treatment if letrozole also fails, because are not very affordable to the patients. We have to keep that cost in mind also. And then we can also use adjuvants like metformin, acetylcholine. Many cases I have seen in my practice also, metformin has been a good supporter in cases of CC resistance cases. So we can go for that. And compared to the clomiphene citrate, letrozole has many advantages. It helps in monofollicular growth, first of all, leading to less chances of multiple pregnancies. Then there is a favorable effect on the endometrium also, because it has a short half-life. CC has a higher half-life, around 2 weeks. So it has the anti-estrogenic effect on the endometrium also. So the endometrium thickness is lesser in cases of CC patients compared to the letrozole. Then there is also no anti-estrogenic effect on the cervical mucus. It is also one of the factors in the patients in which we prescribe letrozole. So letrozole definitely provides a better uterine environment, and there is a trend for higher pregnancy rate in letrozole group than the CC group. Many studies are there which can validate this.
Okay. Yes, ESHRE 2018 has also said earlier Letrose was, banned, but again, Letrose has become the modality of ovulation choice, and it has again provided a benefit over clomiphene citrate and all the aspects which you've quoted. So we'll go to the next question. So, in this case, if on day 12, no dominant follicle seen on ultrasound after 5 days of letrozole, what to do next? Or where do we use the extended? Hello?
Yeah.
Yeah,
Yeah,
it got
able
cut.
to hear you. Yeah.
Where do we use the extended regimen for ovulation induction and its indications, Dr. Mani?
As this is a case of PCO with BMI slightly higher and LH level is also very high in comparison to FSH. LH level is higher. It is because if we have started with 2.5 milligram of letrozole, we can stir up with adding another 2.5 milligram of letrozole in the same cycle for 5 days and then do the follicular monitoring. If we get the favorable result, we can go on this cycle. Either if we don't get the favorable response and no follicles come up with that dose, then we have to cancel that cycle and go for another cycle with starting higher dose of letrozole, or we can go with the gonadotrophins.
Yes. So definitely it can be used as the next cycles is always a learning phase. And as you said, the dose can be extended, or it can be in the form of a stair-step protocol, or it could be an extended regime for a longer duration of days, or it could be a single dose mixed with gonadotropins. So it could be all of these protocols can be tried if the cycle fails, the first cycle, one or two cycle fails with letrozole, with the normal dose. So any other adjuvant which has role in stimulation, Dr. Vandana?
Yes, apart from dietary and lifestyle management, metformin has a very important role because it increases insulin sensitivity. And apart from that, it decreases androgen production as well. So it will decrease hyperandrogenic state. Apart from metformin, we can also use myoinositol and decaioinositol. But these two drugs combination are in the experimental phase. Means ISRE 2026 guideline has suggested that metformin has a definite role, but myoinositol, decaioinositol, and N-acetylcysteine. These all are in the experimental phase. So if the patient budget allows, we can add these adjuvant, but metformin a definite yes. And apart from that, we can also add vitamin D if patient is deficient in that.
Okay,
So
and
rightly said,
do
yeah.
yes, ma'am?
Rightly said, Vandana, Dr. Vandana, that metformin has got a definite role in cases of PCOS, especially with the obese PCOS and when there are signs and symptoms of insulin resistance. So in the workup, we should always see these PCOS patients should do baseline HbA1c, and the signs and symptoms of insulin resistance are there. Metformin, it should be added definitely, and it has got definite role as far as ovulation induction is concerned, because the response improves and even the pregnancy rates improve when you add metformin. So the another case, this is a primary infertility, 5 years. female age 28 years, husband 32 years, known case of PCOS, BMI 40. Oligomenorrhea, bilateral patent tubes, semen parameters normal, 6 cycles of ovulation induction, no success. Any role of lifestyle modification, Dr. Shalini?
Yes, ma'am. Since we have seen that the BMI is 40, it means बहुत ही ज़्यादा है. As per the Indian population, it is very high. Rest of the causes, 28 to 8 years old female, husband 32 years, BMI 40. So definitely lifestyle is a very important role, because even 5 to 10% of weight loss in patients of PCOS can reverse the pathophysiology of PCOS. And now, as we all know, PCOS is now named as polyendocrine disorder. It means it is not just an ovulation, it is everything else. Insulin resistance, obesity, lipid profile, all play a role. Therefore, I think even before ovulation induction, in a 40 years old female, in a patient with 40 BMI, the main thing should be weight loss. As and how the weight loss decreases, the pathophysiology starts reversing, and once the pathophysiology reverses, we will definitely come to have an increased rate of fertilization, and the response to the ovulation all increases once the patient reduces. So little more the first step to reduce weight, because definitely it is going to alter parameters, and if not possible with bio lifestyle modifications, I think she can also go with weight loss medications with a BMI 40. Reasons also, she should go in some weight loss medications despite not only lifestyle modifications.
Very rightly said that nowadays we are
Yes,
seeing
ma'am.
obesity as an epidemic in our country. You all must be seeing that in our OPD, especially the young females, they come with higher BMI. So it's very, very important to optimize the lifestyle, optimize the weight, though it's very difficult, but even the 5 to 10% of weight loss definitely improves the result of the treatment, and it improves the quality of oocytes. And that's why the fertilization rate is better. Everything is better because of this 5 to 10% weight loss. So it's very important to have and to sensitize these young girls who are going to be mothers, who are having all these metabolic disorders, to sensitize these girls about their optimum weight and lifestyle. Not only with the weight, they have to include some kind of exercise in their daily routine. Even the lean PCOS need to optimize their healthy lifestyle by avoiding junk food, by avoiding sedentary lifestyle, because nowadays most of these young girls who are trying to conceive, they are having sedentary lifestyle. They are working in IT sectors whole day. They are sitting in front of computers. Though genetically she may be lean, but her all parameters inside her body may not be very optimum to produce good quality oocyte. So we should sensitize these young girls to have a very good lifestyle that include good kind of food and exercise. So, all the papers they publish various times, and they, show the benefit of weight loss whenever a patient these women is trying to conceive. So is there, Dr. Swarupa, is there any role of laparoscopic ovarian drilling in cases of CC resistant cases, or any resistant cases for the ovulation induction in these PCOS cases, especially with very high AMH? What is your opinion about LOD? Dr. Swarupa, please.
Yes, ma'am. I am in. There are some role, particularly if we do judiciously laparoscopic ovarian drilling, particularly high BMI patient, high LH level, insulin resistance. This group of patient usually responds very well with laparoscopic ovarian drilling. And one group of patient, if the patient is coming from periphery where follicular monitoring is not possible, or आप patient को हर 2-3 दिन में ही बुला सकते, we can call them every alternate day for folliculometry, and this group of patient laparoscopic ovarian drilling is very much helpful. But it have to do very judiciously, following the rule of 4 puncture, 40 watt of 40 watt of current and 4 second and particularly 4 millimeter, not more depth more than that. And if we are doing laparoscopic ovarian drilling, particularly I have done lots of laparoscopic ovarian drilling, but it is helpful where ovarian volume is more than 10 cc. PCO with a small ovarian volume, it is not that helpful because of it may causes premature ovarian failure, or it may reduce their ovarian reserve. So this is a good procedure, but if it is done judiciously and in selective cases only.
Rightly
Where
said that it is a
trauma is
good.
present.
Yeah, so rightly said that this is a procedure which is still indicated, but in the patients who actually need it, it should not be done left and right because it reduces the ovarian reserve. Heat exposure should be minimum. Rule of 4 should be observed. 4 punctures each 4 seconds, not more than 4 mm of depth. The puncture should go. So it is done, and sometimes what happens, you are doing laparoscopy for some other reason, for assessment of tubal assessment and all, and then you see a large ovaries falling on its own weight, and this patient rightly said she has come from periphery, she may not come again, she may not come for follicular assessment again and again, and you can't increase the dose for the risk of OHSS and all. In these cases you can try LOD. Still the role of LOD is there, though it is not a very the indicated procedure nowadays. Everybody is talking against LOD, but still some patients, they have got in some cases the role of LOD is there, and they need this procedure because it helps, it restores the folliculogenesis by destruction of ovarian follicles and stroma, and resulting, especially it results in decrease in the androgen and adipin levels and increases the blood flow also. So there is definite role of LOD. So what would be the drug of choice in case of infertility with endometriosis? Now, this is a small question I've put up, that when there is endometriosis, so which is the drug of choice when we want to have ovulation induction? Whether we should be giving CC, whether we should be giving letrozole, whether we should be giving gonadotropins. Because first thing is that before going for that ovulation induction in endometriosis, there are various things which we test, like what is the ovarian reserve, what is the type of endometriosis, whether there is a large endometrioma and all. But just a small question for the thing is that basic question, that what should be the drug of choice in cases of infertility with endometriosis? Dr. Sadhana?
As you said, madam, it is the letrozole is the drug of choice. But in our case, the patient has already gone through the 6 cycles of ovulation induction. And we have to see what is the stage of the endometriosis. In stage 1 and 2 endometriosis, having patent tubes, normal semen parameters, and particularly in this case, having 6 cycles of ovulation induction, we must go for controlled ovarian stimulation and IUI. But if there is advanced endometriosis like stage 3, stage 4 disease, tubal dysfunction, significant endometrioma, low ovarian reserve, or increasing age, failed IUI, we would move towards IVF. And after treating the other causes of endometriosis like chocolate cyst, we have to deal with them and move to the IVF.
Yeah, rightly said, because my question was that which is the drug of choice? Should we use CC or should we use letrozole?
Letrozole.
Now I would, that's what I would like to emphasize, that letrozole is a preferred drug of choice because of its activity as an aromatase inhibitor. And nowadays we are using letrozole for the medical treatment of endometriosis also. So this is a better drug which gives least side effects and complications, and it doesn't increase or increase the disease process also, and simultaneously it helps in the ovulation induction.
Yes.
So when do we say optimal stimulation has been achieved in case of natural cycles for cycles or for IUI, Dr. Mani Mukta?
In this case particularly, as we have seen that already 6 cycles of ovulation induction has given, and it is written in literature also that we not give ovulation induction drugs for more than 6 cycles. So in this case, we can go with gonadotrophins in the next cycle with IUI if she opts for IUI. Otherwise, she can go for IVF also, particularly after the lifestyle modification. If she is not willing for that, there are new drugs like semaglutide. We can take help of that. But for optimal stimulation, gonadotrophin is the choice for me for the IUI if she wants, but we prefer IVF in this case. And trigger agent, yes, we
Yeah,
definitely
this
want
is,
to give the
yeah.
trigger because timing is very, very important. We can manage timing with that trigger agent for IUI also, for natural cycles also, and for IVF also. So definitely trigger will be, if we go with the ovulation induction drugs, then trigger will be beta HCG, definitely. And in case of IVF, you have asked for IUI, then
I've asked for the natural
yes,
cycle, timed into dose
natural
for
cycle and
IUI.
IUI cycle, beta HCG will be the trigger agent of choice.
So
And
all
definitely
IVF,
trigger will be given.
yeah, all panelists agree to it that we should be giving trigger when we are doing ovulation induction. Dr. Khushbu, Dr. Vandana, do you all
Yes.
agree
Yes, trigger should be
that
given.
Yes,
whenever
yes.
we are whenever we are doing ovulation induction by with the pharmacological agents, we should be giving trigger, and trigger preferably when we are not doing IVF, the trigger should be HCG. Yeah. So the thing is, optimal size of the dominant follicle should be 18 to 20 millimeter. Endometrial thickness should be 7 millimeter, more than 7 millimeter. It should be trilaminar with zone 3 and 4 vascularity. And when we doing ultrasound, when we are doing the folliculometry, the very important thing is that not only the size is important, the vascularity of the follicle is in the perifollicular area is also very, very important. So at least 3/4 of the follicle should be having good vascularity, and peak systolic velocity also should be more than 10 centimeter per second in pulse Doppler. That this kind of follicle will definitely produce a good quality of oocytes and will result in pregnancy as compared to the oocyte which is produced from a follicle which has got poor vascularity. If endometrial thickness is less than 7 millimeter, we can increase 1 or 2 days extra before giving trigger. That is my point. And do you all agree with this? That if their endometrial thickness is 5 millimeter or 6 millimeter and the size of dominant follicle is 18 to 20 millimeter, vascularity is also not very good, would you trigger or would you wait for 1 or 2 days more? What is your opinion? I would like to ask all the panelists, whosoever is interested can answer this question.
Yeah, when the size is reaching about 20 millimeter and the endometrium is lagging behind, we can wait if we have used the pharmacological agent like letrozole or clomiphene and give the estrogen for the endometrium preparation. And then we can wait for 1 or 2 more days and then we can give the trigger agent.
Especially sometimes, what is your, I think everybody must be having this experience here. I would like to, emphasize this point that when you are giving letrozole in high doses, especially in cases of PCOS, if you give 5 milligram of letrozole for more than 5 days, that sometimes we give extended protocol, sometimes 7.5 milligram of letrozole, we always find thinner endometrium because there is low estrogen at that particular time. But this endometrium catches up very fast in a day or two. So there is no harm in waiting before giving a trigger for a day or two. Even we are seeing that follicle is reaching at the optimum size, especially in cases of letrozole. This thing. Now, Dr. Swarupa, when you have given trigger, and do you recommend luteal phase support after letrozole or CC? And what is the preferred mode of administration for luteal phase support? Dr. Swarupa.
Yes, ma'am. Usually, I prefer for luteal phase support in ovulation induction cycle, and I prefer vaginal micronized progesterone and sometimes dydrogesterone also.
Dr. Khushbu, what is your opinion about luteal phase support? Do you give in all the cases of ovulation induction, or you don't give? What is your opinion about it?
Yeah, I do give dydrogesterone in all cases. Nothing more.
You give dydrogesterone in all the cases. So now there is a this thing whether we can give micronized progesterone or we can give dydrogesterone. This is a choice, personal choice.
Yeah, choice depends.
Yes, personal choice, but most of the time, and not most of the time, always we give luteal phase support once we use letrozole or clomiphene citrate.
Yes.
So this is the paper which says that women with PCOS who use letrozole for ovulation induction has higher clinical pregnancy rates when using intravaginal progesterone support. Luteal supplementation with intravaginal progesterone, especially the dosage should be minimum 400 milligram intravaginally and preferably 400 milligram PD. Then the chances of pregnancy is higher in cases of luteal phase support. Which when injectable gonadotropins are introduced, Dr. Khushbu, when would you like to introduce injectable gonadotropin in cases of ovulation induction?
Basically, these are second line agents, ma'am. If the patient fails to ovulate on Letroz or CC, then we can go for the gonadotropins. If there is failed 6 cycles of oral ovulations and patient has not conceived, then we can go for IUI cycles in which the gonadotropins are better than the oral ovulations. So basically, in these patients, we can go for the gonadotropins therapy.
So when we are talking about, now we are not talking about IVF, we're just simply talking about either timed intercourse or IUI. So what is your preferred agent? Do you go for FSH or you go to HMG?
No, I go for HMG only. FSH is very costly for the patients here actually. They are not able to, so I have to keep that in mind, and I go for HMG and the results are very good with HMG also.
Yeah, very rightly said that HMG gives you good result, and then you in cases of timed intercourse or in cases of IUI, you don't want many follicles. You just want one, 2 or maximum 3. Because if it is more than 3, you're going to
cancel the cycle, and that is very
yes. So why to unnecessarily waste the money for the patient, and better to use HMG, and that too urinary HMG is good enough.
Yeah, 75 international units I start, and then we follow up after 6 days. If there is a good follicle 10 mm, then I don't increase the dose. I keep it at 75 only. And if there is no follicle of 10 mm, then I increase the dose by half an ampoule, 37.5. And then we will reevaluate after 3 days. If the growth is good, then we will maintain that dose only. So,
thank you very much, Dr. Khushbu. So, anyone would like to, elaborate on the various protocol of gonadotropins who are here?
Sorry to interrupt, ma'am. Indu ma'am, sorry to interrupt.
Yeah.
I think will we be able to finish by another 10 minutes, ma'am?
Okay, so let me, then we'll not discuss about the, the various protocols. We all know that it's a, just a step-up protocol, low-dose step-up protocol, sequential step-up, step-down protocol, chronic low-dose, step-down protocol. So step-up protocol, we start with a low dose and then increase the dose of gonadotropin as per the response. Step-down protocol, we start the dose with a higher dose and then we go down. That is the basically step-up and step-down protocol. And I will not go into the detail of this thing. And there are various papers which comparison of letrozole to gonadotropins for ovulation induction and who failed to conceive with clomiphene citrate. So definitely gonadotropin has got a better result as compared to the letrozole. So so now just cases, we'll just have 2-3 words on these cases.
Yes,
sure. Yeah. So this patient is 30 years of age, married for 2 years. Her we will emphasize on the her values of AMH, FSH, and LH. So AMH is 1.31, FSH is 0.2, LH is 0.1. And on TBS small uterus, right ovary shows 6 follicles, like AFC 6, left ovary 3. Now, this is a case. What is your diagnosis and how to proceed in such cases? Any role of using letrozole or CC, Dr. Shalini?
Yes, ma'am. Can I just go to the previous slide?
Yeah.
Yes, ma'am. Ma'am, so now अब इसमें देखेंगे we have many points here in this case. Menarche achieve होता है only after OCP. This means it is not just for progesterone insufficiency, it is also a estrogen insufficiency. Semen analysis is normal, therefore it rules out the spousal cause. AMH is there, FSH and LH are very low. TVS is small, uterus, but still we have some antral follicles. So since the FSH and LH is low and the patient bleeds only on estrogen, not on progesterone alone. So it means that there is a ovarian cause, a ovarian abnormality, the cause of which it is either hypothalamic or pituitary. Ma'am, can I come to the second slide? The next slide? Yes. So, ma'am, when we come to the diagnosis, it is basically a hypothalamic pituitary cause to this ovarian failure. So, first of all, when we evaluate the patient, we'll have to find out whether the cause is hypothalamic or pituitary. वो हम हिस्ट्री से पता कर सकते हैं. बाकी हार्मोन लेवल एस्ट्रोजन है, TSH का रोल है, prolactin, and if needed, we also have of the brain to look for the hypothalamic or pituitary cause. So we have now the treatment. Now, since this patient has a low FSH and LH, so since the HPO axis is not working, so giving her letrozole and clomiphene won't help. So we will have to give her either gonadotrophins if there is a pituitary cause, or we will have to give her GnRH if it is a hypothalamic cause. So just giving letrozole and or clomiphene won't help here. And since she has a basic follicles still there in her ovary and the AMH is okay, so we will prefer her giving gonadotrophins or GnRH depending upon the hypothalamic or pituitary cause, but no letrozole, no clomiphene.
So the answer is that here letrozole and clomiphene will not help. Here we have to give gonadotrophin, and that too in higher doses or maybe for a prolonged stimulation. The silver lining is that she is showing some follicles in the ovaries. So this patient may conceive with this treatment. Now, other cases,
Sometimes in hypogonadotropic hypogonadism, the case looks like a poor ovarian reserve. But on giving exogenous gonadotropins, suddenly the ovaries flare up with follicles, and there can also be chances of OHSS. And one thing which we have to consider in mind, the type of trigger. The type of trigger has to be mostly the HCG or dual trigger. Here, LH will not work. Giving just LH will not work over here as a form of trigger. So we need to see that recombinant HCG should be given as the trigger.
And there's one thing more, since this patient has low LH, we will have to give her a luteal phase support because the progesterone is not there.
Yes.
Very rightly said and very nicely sum up the case in a short time. Now, this is another case which is where this, I'll just tell this, the AMH is very low. AFC is 3 in each ovary. Patient's age is 35 years. Husband's age is 38 years. 4 to 5 years of infertility. So just the simple question, will you go directly for IVF or you would like to have IUI for 1 to 3 cycles? Any one of you can answer. Dr. Mani Mukta, Dr. Khushbu, Dr. Swarupa, any one of you can answer this question. That would you go directly for IVF or would you wait for IUI for 2-3 cycles?
2 to 3 cycles, we can wait for IUI.
We can do one cycle IUI if she has not undergone IUI or any other kind of ovulation induction previously, because the age is borderline 35 years and AMH is very low, not very, very low, but it is also on borderline. So we can go for one cycle of IUI if previously not done. Otherwise, if she has undergone previously IUI or any type of ovulation induction,
so she has not undergone any treatment. She's not undergone any treatment?
So we can try for one cycle of IUI in this case.
Madam, for me, while I will do IUI, I will counsel her कि आप एक बार जाके IVF स्पेशलिस्ट से मैडम के पास जाके आप मिल आइए और
Now
वो
the
जो
same
टाइम
case. Now the
टाइम
same case. Okay, now the same case, but the age is 42 years for the wife and
Yes, yes,
45
yes.
years for the husband. Now, what you will do? Will you wait for IUI? Will you
Direct
straight
IVF.
wait?
No,
Direct
no,
IVF
direct
in this
IVF,
case.
So,
direct
whole
IVF.
panel agrees to it that if the age is 42 years, that means if age is advanced age, we should not be wasting even a single cycle for doing any other treatment, but to the confirmed treatment where she has got better chance to get pregnant. So this is very, for
Dr.
age.
Other moderator and panelists are waiting for almost more than 15.
Okay. So we are summing up this case now. I think everything is done. We have taken care. So thank you very much. Thank you very much, Dr. Kalpana and all, giving us this wonderful time for this panel. And I will thank
Thank you,
all
ma'am.
my panelists and my co-moderator, Dr. Kriti, for
Thank
doing
you,
their
ma'am.
wonderful job. And yeah. Thank you very much,
Thank
Dr.
you.
Kriti. If you
Thank
want to
you
have a
all.
word, thank you all. Thank you very much. Thank you.
Thank you, ma'am.
Thank
Thank
you,
you,
ma'am. Thank you,
Thank you,
ma'am.
Indu
Thank you
ma'am.
so much.
Wonderful panel, ma'am, and very clear, crystal clear about the induction. And due to, as we are running short of time, we have to move on.
Yeah.
Thank you very much for the panel. All the members very active, excellent session. Then thank you, ma'am. And then we'll move on to the next session, which is about the setting up of an ART lab. I invite Dr. Adita Shinde and the co-moderator, Dr. Akash Agarwal. So Dr. Adita Bharat Shinde is a chief embryologist at Dr. L.H. Hiranandani Hospital, and she's a scientific director at Uma Fertility, Mumbai, and managing partner of ART Solution LLP, and she also does freelancing. And her special area of work interests are fertility preservation, embryo blastocyst biopsy, embryology troubleshooting, and lab setup. Welcome, Dr. Adita. And we have Dr. Akash Agarwal, who has done his undergraduation and from MBBS, an Asia certified clinical embryologist, and he's a topper, has done his master's in human reproduction and embryology, and also in biotech IVI Spain, and master's in clinical embryology from Mysore, and management committee member of ACE India, scientific committee member of IHERA, an assistant professor guest faculty at Aspire University of Mysore, and a mentor in IIT Hyderabad, and he has experience of over a decade and a half in fertility. Welcome. So we have the expert, Dr. Rahul Sen, who has more than 18 years experience in reproductive sciences. He is a state ART and surrogacy board member in Rajasthan, and he's affiliated to WHO FIDS member, an HR mentor, and a ISAR Youth Brigade member. And he's a certified assessor of quality and accreditation institute, and he has numerous awards from ISAR Shining Star Award and IFS Achievers Award. And also he is a scientific committee member of IHERA and past executive member of ACE, past treasurer of ISAR Rajasthan, current executive member of IFS Rajasthan chapter. And he has contributed to many magazines, and also is an associate editor of ACE, and authored many chapters in the book and publications in national and international journals. So I request Dr. Akash Agarwal to introduce the expert, Dr. Rahul, and Adita Shinde to introduce the panelists, please. Dr. Adita Shinde.
Thank you, Dr. Radhika, for the introduction. And I would like to invite Dr. Sanket Dumal Satya. He is a SHA certified clinical embryologist working as an assistant professor, prestigious member of FIGHTS, WHO, a space researcher, and a host of awards to his name, including the Economic Times Health Award, ISAR Star Award. Welcome, Dr. Sanket. And I have the pleasure of having Dr. Sanjay with me. He's a senior clinical embryologist a freelancer with over 18 years of experience, has been awarded the IFS Achievers Award, ISA's Rising Star Embryology Award, a member of ACE Executive Committee member, and authors in multiple publications. Welcome, Dr. Sanjay. And next, Dr. Dayanidhi, an expert member for Bihar State Board, Joint Secretary for IFS Bihar Chapter, President of Bharat Association of Clinical Embryologists. He's heading the Patna branch of Indra IVF Limited, where is the center head as well. And again, over a decade and a half year of experience and more than 10,000 plus embryo transfer. Welcome, Dayanidhi. And I have with me Ram Prakash, founder and scientific director at Myri Fertility, Noida, Delhi, NCR, co-founder and scientific director for Angel Fertility, Nepal, a visiting consultant embryologist at Max Super Specialty, Delhi. Again, more than 10,000 cycles of experience, more than 14 years into the field. Welcome, Ram. Thank you. So I think we have a very rich panel. Each of the panelists over here have more than 10,000 cycles at least experience under their belt, and all of them are very good friends of mine. So I welcome all of them. And first, I would like to begin with saying thank you to the Blossoms Group and Dr. Kalpana for inviting us to have a webinar on a topic which is very apt. I know it's something which comes to the mind when any gynecologist or infertility specialist want to start a IVF lab, ART lab. What is the important thing that's going to be there? What is it that they have to be doing? What all things they'll be requiring? We have tried to simplify it a bit, keep it in a relatively simple language, going into the technicalities, but at the same time, not going too much into the nitty-gritty of it. And with this, I would just start. Is my screen visible?
Yeah.
Yes,
think
yes.
it's right of you.
Yeah. Okay. Thank you.
Yes.
Second. Yeah. Yeah. So I hope the first question is visible. So if all the panelists can please unmute and themselves and the screen is on. Ram, you are there?
Yeah. Yes.
I just cannot see Ram.
This must be driving.
Is going to join? Okay. So first and foremost, you know, the ART scenario has been changing over the decade and a half. The practice, there has been too many ups and downs. It has not been a uniform play field. So the Indian government, though there was a bill which was proposed way back in the early 2000s, it took them more than a decade, probably a decade and a half, for it to be passed. And then they finally came up with the ART law, which was passed in the 2021 December 18th, and it became a law. So what regulatory approvals are needed before you set up an IVF lab in India? Before even you think, okay, you're going to start, what are the things which should be there at the back of your mind? So we'll start with Dr. Sanket.
Yeah. So, well, coming to the regulatory approvals that we need basically for setting up of an IVF lab, either it could be level 1 or level 2. See, first and foremost thing is you need this regular licenses like Clinical Establishment Act license, that is shop license. Then you need this fire safety license, biomedical waste management license, that is mandatory. And of course, your pharma license is also mandatory. Then having all this, you can apply for PCPNDT license since we use ultrasound in the clinic. And once it is there, I mean, including all this, you need to put together in this thing, then you can go for level 1 or level 2 license.
Okay, so these are mandatory, which are across pan-India. Since we are panelists from different states, are there any states which are asking for anything specific, different licenses which are state pertinent? How much they are, how strict they are regarding the fire safety license in all the states? We can have from all the panelists as well as the expert as well, and biomedical waste as such. We'll take all the panelists, starting with you, Dr.
So what I feel that, most of the, states will have very, uniform licensing, at least the licensing certificates. Like for clinical establishment, you need to have, fire, that the gynecologist name and all the thing, biomedical So even the air quality, air pollution also, that you need to have that license. And once we submit these, all the license will get the clinical establishment. And then for the getting PCPNT, you need to add on these all the licenses. After getting clinical establishment, you can apply for the. So I don't think that these are the most of the licenses which Dr. Sanket has said is compulsorily, is a mandatory, and we cannot process or we cannot go without these licenses for the ART practice.
You are in the state board, right, Dayanidhi?
Yes.
So what is one license or area where you have probably found missing? What common mistake is done in terms of this licensing for someone who is starting afresh? Anything you would like to highlight?
I think on paper, there's no missing license. There's no missing.
Okay, off the paper, if not on paper.
No, because see, we have got the ART state board, but that's not fully functional. So after getting the license, the audit or the inspection is still it's not happening. So because of that, the maybe the appropriate authority or the PCPNT department or civil surgeon, they don't have that much experience in inspecting the ART or level 1 or level 2 clinic. They don't have experience. They just check the basic licensing part. Whether it could be the fire, it could be the air, it could be the biomedical, but they don't go beyond that, like the number of equipments or lab or something. So that's part we are missing in Bihar at least.
Okay. Dr. Sanket, you want to add?
Yeah, just to add what Dayanand has already said. See, if you look at it, at least in South India, I think there is no stringent laws that you have to check the qualifications. I mean, they do check qualifications of staff, especially an embryologist or other ancillary staff. But what is missing is, I think they're not checking the number of cases they have done earlier, because that is very important, because they just say they claims on paper are different than actually doing it in the lab, right? So they say we have done 500 cases, 1,000 cases, but is it validated by a supervisor in the previous clinic is what matters. That has been not checked, basically the logbook.
So how do you think?
Telangana, because I've joined, we opened a new clinic here in Hyderabad. So when we applied for a level 2 license, they asked for a logbook. So I had to submit my logbook. This is the first state which asked for a logbook. I mean, I was super impressed.
Yeah, logbook is something, probably we were maintaining only during our training phase, and later if we are the solo embryologist, we no longer maintain the logbook. But this is an important thing, probably what juniors from the embryology, and probably a message across to the ops and gynae and the owners or managers of the clinic is to keep it mandatory. It will be helpful for each and everyone.
The sad part was I had to procure my, I have to get my number of cases from all my places. It was a little challenging for me because I have to call them, I have to calculate. I mean, I'm still going forward. I think that is very important, is what I feel.
Okay.
I think these all things will be very, very essential when we'll start the state board will start inspecting all the centers, and they will look into each and everything.
Yeah, I agree with this, but do you think there's a practical difficulty in getting this verified? At the end of the day,
definitely,
there has to be a line where it has to be drawn. I mean, where it ends, somebody might already be feeling that the law is already overboard in terms of things. There always will be two sides of it. So don't you think that it may be a little bit overboard if we go into checking of the logbooks? Because, it may get practically difficult.
No, it is very important, I feel, because, as I said earlier, I think you can put anything on paper, right?
Yes.
But you need proper validation for that, because suppose, say, a person has worked in so-and-so place earlier, it has to be, signed by a clinical director or a medical director, or at least a senior embryologist. Otherwise, it has no value, right?
Yeah, so those will be signed and put. Obviously, logbook will have a cross sign of them, but to get it verified may be difficult. Maybe something like how we have a medical council for doctors. Similarly, since I'm registered with, and I know you don't have certain things to follow, certain ethics and laws will be there governing certain CME points compulsorily. So that way it may be there, but the field is still in the relatively novice stage, I would say, and it may take a bit of more time before we get over there. And since we are discussing about this, since we are discussing about the qualifications, I would like to take this question earlier, which was put a bit later. What are the mandatory personnel and what qualification does the law require? Before that, I would like to break it into two. What are required mandatory by law for a IUI lab or a level 1 clinic, and what is required for a level 2? So if we can have answers for this.
Well, to start with equipment, it is very simple for level 1. We need one lab, one microscope, one centrifuge, and of course your storage tanks, liquid device, and your compound microscope. Otherwise, nothing much that goes into level 1 clinic. But personal wise, I think you need one gynecologist, and of course, if you look at law, there's no mention of an embryologist there in the level 1 clinic.
No embryologist there, yeah. And in addition to gynecologists, any other thing mentioned?
Yeah, if they're using ultrasound, I think, yeah. And also, since they don't do any procedures based on anesthesia, so it is not required there.
Right.
And counselor is required. So that's the thing what they mention in ART law. But coming to level 2, they're very stringent. And we need a gynecologist who's qualified as an IVF specialist. And for also, they have specific set of qualifications for them and minimum number of procedures that should have been done to qualify as an infertility specialist in India. And coming to embryologist, we have huge page of qualifications that qualify, starting from BSc to whatever, PhD, MBBS, MSc, MCE, and plus along with these degrees, you need to have certain amount of years. For example, a person who has done MSc Life Sciences, he has to practice in a lab for at least 3 years to qualify as an embryologist as per the law. And person who has done MBBS, he has to do MCE again, which is Masters in Clinical Embryology, and 1 year, 2 years of experience will make him an embryologist. Of course, and again, coming to the equipment, again, we need, of course, anesthesiologist, radiologist, andrologist, counselors, and again, you need a huge set of equipments, incubators, gas CO2 incubators, and also your lab, and also your micromanipulator, and this includes the level 1 setup as well.
So, Sanjay, you want to add anything to this?
Sanjay, hello. Ram, Ram is there.
Ram has joined?
Yeah.
Yes, I have joined. Hi.
Yeah, Ram. Hi, welcome. So you had heard about what Sanket had just told. So anything addition to it you want to add? What are mandatory requirements
For level 2, so I have some addition to the previous question is like, in states like Delhi, and if you look at the UP, these are like very close by states. In Delhi, you do require a logbook, and that too with patient number, because in that, the appropriate authority or
Ram, we can't hear you.
Hello, Ram.
I think there's some signal issue.
Yeah, maybe. So anyone want to add any points?
Our expert, Dr. Rahul.
I think I discussed consular is very, very important part of
No one is
this
there,
ART level 2. So I think consular is, and the rest of all is said by Sanket. But I think consular is one additional thing that should be graduated in psychology, clinical psychology, or nursing, or life science. That's very important. That's the additional part of all what Sanket has said.
Okay.
Rahul?
Yeah. Hi. Am I audible?
Yeah.
Yes. So, thank you so much for punching up this great discussion, and which is of very much requirement. And as we are discussing this part, that what all is required in level 1 or level 2 clinic, already Sanket has mentioned all the things regarding the qualification of each and every member. But what we require at the time of inspection is all the team members should be there at the time of inspection with all their qualifications, with all their documents. Has to be verified by the clinic director, because the verification which we were discussing, this onus of verification has to be there on the clinic director, whichever the name is mentioned as the director in the clinic, the one he or she is going to be verifying that this number of staff is there in the clinic and they are qualified with this particular criteria. So this has to be done by the clinic member, and that will be the final call for the submission of their qualifications. And with the number of equipments, yes, there is a long series of requirements in the name of equipment which is required, like
Go into the
incubator,
detail. we'll go into that detail a little.
Yeah. That is the long list.
I mean,
So
yeah,
yes,
it's
that
a long
is
list and a
again a
long part of
mandatory
the
part.
program.
And again, this the equipments which has to be there, they should be in the working mode. They should be well installed, set up. It should not be like that. Yes, the equipments are in the purchasing side. It is coming on the way, or it is something not installed in the lab. So it will not be considered as a part. It is not installed. So equipment has to be there in the place. So that is all I wanted to say.
Okay, so we'll quickly go on to a next question, where in terms of ART law is very clearly differentiated to clinics, level 1 and level 2. So quickly, what is the difference between a level 1 and level 2 clinic in just a couple of lines?
So, well, level 1, we just do ovulation induction and up to IUIs, and also someone facing for the same self guys who's willing to try for IUI. And level 2 is we can do up to starting from semen analysis to PGT.
Yeah. So anything where you are handling other than semen outside the body, you require a level 2 license. Simple as that in that terms.
Yes.
And just to add to the previous question also, counselor, as it was said, is one of the important things. And if you see, it's there mandatory even for a level 1 clinic. So something which is very important part of our, ART field as such is counseling, and it has been given its due weightage. Something we see counseling is not given that much of a due weightage in tertiary fields, having a separate counselor, the amount of emotional weight attached with it, the consequences of the decisions, the long-term nature of the treatment, all these things have played. They have formed a parliamentary committee actually before coming up with this law in 2000, way back in 2012 and 13. They had visited multiple places across the country, and they have done a good job to that end, I would say, including these persons as counselor compulsory and a nurse for this. And I think there's nothing much between a level 1 and level 2 clinic, just if you can plainly remember, as sperms and IUI over there, anything beyond level 2. Anybody wants to add anything?
I think
And also, if in the cases where the stimulation part cannot be taken at the level 1, if they are taking it, there has to be MOU between level 1 level 2. That is very, very important, because that's what something we all miss. And we think like if you have a level 1 license, they can start stimulation, but actually they cannot without a MOU with a level 2 clinic, and that doctor has to be registered in level 2 fertility center or level 2 clinic.
Yeah, completely agree with Ram, because see, with corporates and all, which has a hub and spoke model, it does work because they're all under the same umbrella. But having a standalone level 1 clinic, you cannot.
Okay. So are we saying it's legal to stimulate at a level 1 clinic which has MOU?
Yes, it's allowed.
It's allowed, right? You can stimulate, you can
If
monitor.
it is hub and spoke model.
With a hub and spoke model, yeah, you have to be attached compulsorily with another clinic, and you can do that. Only thing is you cannot do anything beyond that, anything beyond the stimulation. Okay, so we'll quickly jump to the next question. Atita, will you tell me?
What is the requirement of IUL lab and procedure workflow? Hello. Can
Yeah,
you?
you're audible.
Yeah. What is the required to set up an IUL lab and procedure workflow? So anyone can. So we can ask. Sanjay is here. Yeah. Sanjay.
So IO lab means level 1 we are talking, right?
Yes, Sanjay. Level
Yeah.
1.
Yeah, to be precise, that is why I asked actually. So for level 1 setup, we need a flow unit, then we need a binocular microscope, compound microscope, you need a centrifuge, you need a incubator, and you need a cryocan. If we talk about the technical things, equipment things. Yeah. And for the setup, we need a separate IO like a lab, and then we need semen collection room, also IO room. Yeah. If anybody else wanted to add, and they can.
Okay. Any particular things required there?
See, for procedure workflow as such, like first thing first is recruitment of the patient, then goes the counseling. Then, we talk about only for us semen IUI processing for IUI procedure. Then we need a separate semen collection room. Then the
Yeah.
proper identification should be done for the collection jar. The proper patient ID should be put on that, and the uh, the person who is handling the sample and also the witness, that should also be in the workflow. I should take care, and the rest is the technical thing that then you follow the procedures. Yeah. And for ARTs, one point I would like to add, for donor samples or something, you're not like nobody can store the donor samples in advance. Yeah.
So I would like to add one more point here, in addition to all the points. We have seen certain clinics or certain, instances where, patient give their relative sample and they claim that this is their own sample. So there must be one CCTV camera also that is required when patient come out from the collection room, until, it must be, proper, supervised by the staff with the witnessing system, so that the same sample should reach the lab or embryology lab, proper washed, and the same sample would be used. So that there are many instances. So I think CCTV camera installation is very important in IY setup also.
I completely agree with Dayanidhi, because see, center do verification does matter, but especially when it is a home collection sample, you need to take a consent. The moment the sample is reaching your clinic, you need to take a consent saying that so-and-so sample belongs to so-and-so person and writing. Otherwise, you are in soup.
That is declaration actually. That patient should declare that this sample belongs to him only, and if there's any error occur in future, the patient will solely be responsible for that.
Yes.
Yes. Sanket very rightly mentioned about the consent or declaration, because sometimes patient insist to bring the sample from home because they're not able to collect at the lab. We can't force them to collect at the lab compulsory. For this documentation is very important.
Yes.
It's a very difficult situation where patient insists, and certain times where you suspect foul play also. Then in this case, it is your documentation which is going to help you. Maybe a CCTV footage attached with that. We all have faced. I have faced one scenario where we had a different person. We had a spoke clinic, and we had another person going. I know Sanket is smiling because he was with me during that time, probably, where we had another person attending all the counseling sessions in the spoke clinic, and a different person coming to the level 2 clinic and giving the sample. You can imagine how difficult it would become to track, going by the government IDs and everything. And this was realized post trigger that something of this sort is happening. So you need to be really on your tenterhooks, assume that there can be a foul play at any time, and go by your instincts. Sometimes it's never, too much. It's to be safer, on the safer side with these things. Yeah.
And also, I would like that small thing here. While taking the consent for the home collection samples, make sure that husband and wife both will sign on the consent. It's not just the husband, it has to be both.
And also on the simultaneously, you can take an Aadhaar card or something like that, So that will help a lot.
You can have the Aadhaar card, and if it permits, you can have a facial recognition software installed inside.
Any government ID you can add it.
Because we know how well the Aadhaar photos correlate.
Can I jump in here?
Yeah, Rahul.
Can I jump in here? So, as we are discussing this consent part, so your consent has to be completely filled by the patient as a couple.
Rahul, we are losing you in between.
Where female is the wife and audible. Am I audible?
Rahul, we can't hear you properly.
We heard you are audible. Now we are audible.
Now it's okay. I think.
Yeah.
Okay. So this consent has to be taken as a couple from the female and male, And in the you can take it as Aadhaar card. This not only consists of Aadhaar, but we can take as a marriage certificates. Marriage certificates can be taken because we ourselves has to assure that they are the couple, not only on the documents which is being written by them, but also a government ID or a government certificate which is there to verify the both partners as a couple. So that has to be mandatory, and it is already recommended by few state boards also that it is better to take marriage certificates, and if the marriage certificate is not there, better to take a affidavit that is for the marriage. So it is a mandatory part again for few state boards, but few state boards they are not actually recommending it. Just to take the Aadhaar cards, get the signature done, and you can complete your consent and do the procedure later on. But only when the consent is there, consent is properly given, then only perform the procedure. Without consent, do not take any patient, any partner, even do not give husband or semen sample container for the semen collection for the procedure of IUI or anything. So better to take consent first, counsel it properly, and then only send the patient or the couple for the procedure anywhere in the premise or in the unit.
Yeah. Consent is required. So I think just to sum up, there are so many factors over there rather than, one is your registration and its pre-requirements. You require the minimum lab in terms of, semen collection room, a basic andrology lab with a microscope, centrifuge, and maybe a test tube warmer or an incubator for sperm wash and preparation, sperm preparation things. And if I had been missed out, very important, a fridge, if it can be pharma grade, especially since you're doing IUI, cryo tanks may be required, plus the very important part about documentation. That's the area where you have to concentrate a lot, because that's where the problems are going to arise. So we'll move on to we have seen so many things about when we think about a lab setup, probably the things which come to our mind is where it's going to be, what all things it's going to require. So we are now moving on to the core area of it in terms of what would be the ideal space, roughly a minimum space required for an IVF lab. Luxurious labs can extend into hundreds of SFT, but what would be the minimum space required, and which areas would be this? So we'll take it from Sanjay or Ram.
As such, if you look at the law, there are no such minimum or maximum area which they have given. But based on our experience, and like if you talk about functionality of an IVF lab, there has to be, if you talk about complete standalone IVF center, it has to be minimum of 2,500 square feet. It should start from 2,500 square feet, where you at least have a 10 by 12 lab and 10 by 12 OT, maybe 8 by 10 of your andrology. That should be the minimum criteria, which is like based on our experience, where you can actually have functionality and also maintain the air quality of your IVF lab, of your IVF OT, of your andrology, of your cryo room. And also there are some, ignored areas. Like if you talk about cryo rooms, most of the labs, they put their cylinders in andrology, or some of them will have 1 or 2 cylinder, one in andrology, 1 cylinder in embryology lab, 1 cylinder in OT. So it's better to have a cryo room, separate cryo room. And also a record keeping. With the new law, we have to have a record keeping room, or else a record keeping dedicated area for this. Collection room is very, very important. So if you look at all these rooms and all these, practical usable space, minimum should be 2,500 square feet area. That's what, like, from my end.
Yeah, Ram, very well said. And it is including the unsterile, semi-sterile, sterile area. And for only lab purposes, even I have all labs, mostly 10 by 12 labs, 10 by 12 OT, and then around 8 by 8 or around that andrology lab, which are there mostly prefer to andrology lab, one near to the IVF lab, which will handle the samples dedicatedly for IVF lab, then another for IUI room. And then you have washing area. For that, like how 1,000 square foot is mostly sufficient. And then comes the recovery, and then unsterile, and then the considered. So 2,500 to 3,000 is area would be sufficient. And also then again, everything depends on your workload, your number of patients. So this is with this requirement minimum like suppose the minimum load of the patient, we can start with that. Yeah.
Right, right. So there's no definitely a minimum or a maximum as done by law. Obviously, it cannot do that. So as said by Ram, around 2000, 2500 SFT would be sufficient for a standalone. Can we have some idea what would be required, since many of the obs and gynae people would already be practicing? So what would be the area if somebody has to allocate, if it's a already functioning hospital, say of on obs and gynae, and they want to expand into IVF, how much area should they be allocating? What is the like on the roughly on the lower side to have a smooth functional?
Again, if you are planning to have an independent unit in an hospital, like how you have these days, we have a concept of super specialized OPDs and super specialized department. So if you talk about so I work with Max Healthcare also, and here we have our IVF unit separately. So if you talk about the area which we have in our department, also somewhere around 2000 square feet,
That
because
would
we
be
have
similar, Ram, that would be similar to a standalone. So I'm saying a gynecologist who's already having a practice of their own wants, and the hospital, in their hospital, they want to start a IVF unit for themselves. So how much separate area do you think they need to allocate? That was the question.
1,200 hours?
Yeah, I think just like how Sanjay
sufficient.
mentioned that you have to have a like normal waiting area, then semi-sterile area, then sterile area. So if you talk about semi-sterile and sterile area, it has to be somewhere around 1000 square feet.
Yeah.
Semi-sterile
Minimum.
1,000.
That should be minimum,
So,
yes.
Even in places like Mumbai and Delhi, which are very space constrained,
So
with each SFT would be
in
a
square feet,
difficult.
like lab and everything, like I fully IVF center. So within a 1,800 to 2,000, we set up all the lab, then your storage room, changing room, recovery room, consulting room, waiting room, everything is included.
What is the sad part about us is in some cases they do have a space, but they have a lot of space for waiting area for doctors consultation chamber, big chambers, big waiting area, big patient room. But when you talk about IVF and OT, it's a very narrow rooms and narrow space where people the machines are overfilled, or the space is minimum for the embryologist for the movement. So I think it should be equally divided.
Also difficult for any new machine we are installing, or cylinders or anything like that.
They are customize the lamina flows and all. So accordingly that it comes, they take a that measurement and all, and we can set up like this.
I would say that's why there's a core over here written, and you don't disturb your core, your OPU area and the embryology lab. These are your core areas. Don't disturb them. You require roughly 250 to 300 SFT for these two combined.
Yes.
Even what Ram was mentioning earlier, I know you can be luxurious side if you allot more, always well and good, but 250 to 300 SFT. And I would say I would differ a bit in terms of the minimum area required to set up a IVF unit inside of already functioning lab, already functioning hospital. I would say 500 to 600 SFT of separate area where you can have shared post-op recovery. Patient reception would be similar since it's the same gynecology. So I would say 500 to 600 SFT. There have been labs which are functioning well, even doing 20, 30 cases a month. So I would just want to get that point across. Yes, 1000 SFT always welcome to have, but space is something in a pre-existing unit which is very much difficult to take out extra space for that. And embryo transfer room, do you views about it? Separate, Dayanidhi, Sanket, ET room, separate.
We have separate embryo transfer room, but I think same room also can be used for the oocyte pickup where we do. So that can be planned in the morning and evening part. So it's not that that's a mandatory. If you have that, that's always good. And keeping in mind that we should be able to move the trolley or the patient when we're shifting, that area is also required, because when you shift the patient from OT to post-operative, because they are already in the anesthesia, so they should move properly with patient safety. That is also required. So these all things should move properly, and all equipment, big equipment should go in the lab properly, so that all space should be considered when we plan the the IVF setup.
Any specific thing you'll be taking care when you'll be designing where cryo storage room is? One important point I'm looking.
Ventilation is very important. Ventilation is something which we always miss. Most of the lab, they have liquid nitrogen room, but they don't have ventilation. I think that is very, very required and is
ventilation.
Mandatory. Yeah.
And One more. It should
Oxygen
be the
alarm
nearest to the
definitely.
exit, if possible,
Yeah,
in
yeah,
the
true.
event of fire or an
Yes.
untoward. Because I know each and every embryo is important, but then it's 5 to 10 cases, say on an average, versus your hundreds of patients' embryos sitting over there.
Yes.
So it should be as near to the exit as possible. And your rooms should all, like Dayanidhi already mentioned, they should be well connected with the, like trolley should be able to pass, and it should be connected to a lift, because God forbid that one unlucky or unfortunate incident of a patient being required to shift to a tertiary center for standalone centers, that is the day all these things are going to help you. That is so. Any other panelists want to add to this in terms of
I
basically
think
the
the
point?
labs which have a separate ET room should have a separate biopsy tubing room.
Yeah, I mean those who can acquire.
Come on.
Because
People
many
are
of the
still struggling
conferences
here.
we always ask the same question: do you have separate biopsy area or biopsy or tubing room?
See, if you look at it,
that's
if you look at it, even countries like Australia, New Zealand, and even some places in US, they have separate dedicated cryopreservation room as well as biopsy rooms, right? Here we are talking about second OT, which is which has to be for embryo transfers. Because again, I think it depends on the number of cases you're going to handle in a center. Because say it's a busy center where you do at least 10 cases a day, you can't wait for entire day for FETs, right? So if it is a parallelly, there's another OT which is dedicated for embryo transfers, I think it's well and good.
Yeah, but
Biopsy
I
is a
think,
luxury actually.
but
Biopsy is a luxury also, right?
yeah, no, but I think as per the law, they have not asked any separate area or separate room. But yes, it has to be adjacent near to the IVF lab if it is there, and if it is there, you are maintaining and managing separate rooms, then it has to be proper connected, and there should not be there should be less chances of error which can happen, like
Yeah,
good
it should be
spacious
as secluded
floor
as
and
possible.
everything has to
yeah,
be there.
As
Yeah.
secluded.
it
So
should be
just one.
sterile equally to the lab. Yeah, sure. Yeah,
Yeah.
if you're thinking
Equally or
about it.
probably more sterile. Just one last question, which I've faced during lab setups, probably many of you have also faced. Can you not have a separate IUI room and do IUI in the OT room itself? This is one common question. Why to waste some extra space?
No,
As per the law,
most of the
Yes, we
centers
can do. We can do. We can
can
do.
do,
No,
but
You
most of the
don't have
there's
centers,
to.
as per the law, okay, they required a IUI like insemination separate room only.
no.
But
no, there is
So
nothing
very
like
simple
that.
No, they're
here.
not mentioned
Actually,
in
No,
law.
nothing like
what we
that.
can
no,
Nothing
do,
is.
not mentioned in law.
suppose you have separate embryo transfer room that can be used for IUI purpose.
IUI room, yeah.
Yeah, that's
No,
it.
that can
I'm
be
saying
used.
they have only one room. I mean,
Yeah.
someone is doing IUI in the same room. Obviously, they would not have a separate ET room for saving space.
So basically, we have to take proper precaution about the sterilization, right? Or
Yeah.
for the patient also,
Exactly.
they should take proper, PP kit or PP, not PP kit, but yeah,
No, no.
definitely
You can do
sterilize,
your.
I'll tell the reason.
Sterility would be a concern. I'll just cut short
yeah,
one
that's
or
the-
one at a time. One at a time,
Yeah.
please.
So
Yeah.
definitely there should be a clean autoclave, scrubs should be there, the proper masking cap and all, so that we need to consider them as a potential infectious
Infections
object.
can occur.
So, yeah, so we need to take proper precaution.
With proper
I think
precautions,
that
it can be done.
IUI has to be done same way like how you do ET or a womb
Yes.
pickup. Then only
Yes,
it
yes,
has
yes,
to be the
yes.
same room. Otherwise, it should not be same room.
Okay.
Yes.
Sanjay.
Yeah, exactly. You that I have seen that some labs, the space they don't have space or different OTs. They're doing the regular scannings there. They're doing their IUS there, but taking the precautions equally as if you're doing the pickups or other thing. They're properly going with the scrubs. Patient go with the in the patient
They
gown
can.
with sterile gown and all. Yes, we can use the same. There is not such
Preferably
rule that.
not, but if you're short of really short of
Yeah,
space, then you
obviously,
can.
see, that is
Preferably
what
not.
that is. If you have sufficient space and you can spend money, then people will have like one for a thaw ET, one for a pickups, and one for a biopsy. So
Yeah.
then there is sky is the limit.
Yeah,
So
I know,
Yeah.
Sanjay, you may have
No, but
luxurious labs, but sometimes some people are not so
exactly.
lucky,
Yeah,
not
yeah,
so
yeah.
lucky always.
Again,
So
again, one thing has to be taken care in one's mind, that we are going to introduce one of the gamete. In the IUI procedure, we are introducing one of the gamete into a female body, and that
Yes.
gamete is prepared very precautiously in an andrology lab. So if the place where we are introducing this processed sperms, it is not sterile, it is not properly well managed or maintained, then these sperms or these gamete cells, they can give shock to the female body, and the shock can be detrimental at many times. So
Yes,
it
true.
has to be properly managed and maintained the procedure for IUI where it has to be done.
Okay, so we'll quickly go on to the core part further. So we'll take views of Sanket. Anything he wants to add on the previous one, or go on to the next question?
I think pretty much covered. I think we can move on.
Okay, so in terms of air quality and HVAC standards.
Well, at least in India, the law doesn't say anything about air quality. Though
Ideally, I mean, it's not about the
Yeah.
law anymore. I think the law part is majorly done in the
But
first.
what about you think?
True, agreed. So, but see, clean room technology is a new thing. Earlier, all the labs, we could be West or India or anywhere else, people used to run with the normal, split ACs and with labs. But last, I think it's been 2 decades for now. I think people are very much conscious about clean room technology, VOCs, air quality, contamination, and all. So I think they started with this clean room technology, and the AHU has become like part and parcel of any IVF lab. So because say at least if you're meeting ISO class 6 or 7 is well and good, and aim to 5, and your target should be 5, but at least you're reaching, and 6 and 7 is pretty good.
Yeah. Now,
anyone who says they are ready to work in present scenario without a HVAC system, there might be some labs with moderate. Do you really think it matters that hugely?
Literally.
I think yes,
So,
because see, if you look at it, the success rates back then was, say, we used to say 35% is the success rate, right? Now we are touching 60. I think all this adds up, right? Because the environment where the embryos grows has to be monitored, because VOCs was not a concept back then. Now it's a big enemy for us, right? We like talk a lot about VOCs, that VOC, these VOC, right? And it all does detrimental for an embryo. So I think all this adds on at least 5% of success rate. If it improves 5 to 10%, it is significant, right?
5% is huge.
Yes.
5% in IVF is huge. We are struggling for 1% improvement.
Right.
So the message is 10 years back, a decade back, maybe HVAC system would feel non-mandatory, but anyone going for a new setup and without the space constraints, or try to include as much as possible, that HVAC is almost a mandatory. Anyone who
Yeah.
differs in this?
Yeah, actually, there are some old labs which are already running. I understand that that is for sure. I will say air quality is one of the major factor which impact the results. So, but even though by choice, there are some people have space because of space or the setup. It's not possible for them to introduce the HVAC system in the whatever the already running lab. So for them, we have option of portable air filters. So we can have the air circulation, we can increase the air circulation with the portable also. With the portable vent, we can put the pressure. Also, we can have positive pressure model. With that, we can maintain the good air quality, and we are getting good results with that.
Even Dr. Akash, I have to say here, it is not actually only about the HVAC or the AHUs. It is only about the air exchanges that has to be done within the IVF
Yes.
lab, and those air exchanges has to be through proper filtration, whether it is
Yes.
a UV filtration, HEPA filtration, carbon filter, or alum filter, anything. So not only the AHU, which is the routine traditional one where we have to install on the terrace of our clinics. There are a few standalone AHUs, standalone air exchanges, or the device equipments are there in the market. They can be easily installed at near to the adjacent room of your IVF clinic, and it can give you completely same type of result and same air exchanges as the AHU or the traditional HVAC system it does. So
I
it is
agree.
the
I
air
would love to
exchanges.
go into all the details, Rahul, but since we are already running a bit short of
Running
time,
of time.
we can go on. Each question itself would be less for a webinar.
Yeah,
I mean,
yeah.
for that way, a webinar would be less for each of these questions. I would say, rather other way around. Atita, would you take the next few questions, and probably what usually we equate essential equipments and what are the core part of a lab setup in terms of the technicalities, and the most interesting part at the end.
Yeah. What is the essential equipments list for the embryology lab? So, yeah, we can ask to Dayanidhi. Please go ahead.
Yeah. So I think minimum we can start with a microscope. That's a very much important. Then 2 incubators. Then if you're doing ICSI, you have ICSI machine, laminar flow, macular chamber for the sperm counting, centrifuge. And I think for ovum aspiration, there is ovum needle, aspirator. They are the very, very basic equipment which is very, very, essential for the ART lab.
Yeah.
And if you are doing ICSI, then definitely you need to have anti-vibratory table also. That is also part of now the equipment list when we talk about the IVF lab. And most importantly, two embryologists. Even if you're doing one ICSI or 100 cycle, you need at least two. So one can act as a witness and one can act as a, the senior embryologist. So depending on that, minimum 2 members would be there in the lab.
Yeah,
I'm
I would
happy
like
that
to
you
ask
said 2
about-
members and not 2 embryologists, because I was
No,
like,
I'm just
finding one
telling
itself
you
is
2
difficult.
members, one senior and one
Yeah.
helping hand.
Yeah, I would like to ask you. You told me about that. 2 incubators. So which one you want to go ahead? There is like a benchtop incubators. Okay, then box incubator. So which one you will prefer?
I'll prefer one box and one bench top. But yeah, even if you have
What is the
two
specification for
boxes.
that? Why you want to go ahead with these 2?
I'm very comfortable with bench top.
See,
and
actually, yeah. For
I'm
box
very
and bench top,
comfortable for
they
separate
have their
chambers are there for separate patient. The control, control of the temperature environment would be much better. Definitely 2 box also we used to do before 10 years. We used to have 2 Hera cell and used to culture. So it's all about the innovation and the advancement. That's it. So we can go ahead with 2 Hera cell or 2 box or 1+1. That's also fine.
Anyone
Okay.
who at least wants
One-
that time lapse is essential.
Yes, I think five cryo cans. One is for sperm, one is for embryo, one for an infected sample, one for storage, one for transportation. That's very
yes,
important.
very
Yes.
That's
important.
Minimum
luxury.
5 cryo cans.
Physiology.
People
Uh,
will faint. Ram. I know what
Doc-
you're saying is right, but people will faint the moment they hear 5 cryo cans. Just
Dr.
No,
Akash,
if you are buying all the equipments, I think these are the one of the must
I-
add-ons.
Essential.
like I
Yeah.
said, I agree. I agree with you. I have in my clinic, 5 plus 1 extra for unforeseen, plus those things when it is required. But that's the point. That's the point.
yeah,
agree.
I think eventually that one big storage, then one for embryo and one for, so minimum 3 are there. So Ram is telling only just 2 additional, and see, by the time they come, and every lab land up in having 5 minimum cryo cans actually. Yeah.
No, even the law allows that. Law says that you have to have a separate can for infected samples. It's
Yeah,
clearly
obviously,
mentioned.
yeah, obviously it says it is
So
it is
you
there.
basically
It is.
require 3 minimum assets: one
Yeah,
for
yeah,
embryos,
okay.
one for sperm, and one for infected samples. Law does
Yes.
not mention separately
And
for
backup
infected
also.
sperms
One is
and
backup.
Yeah.
that
One
one.
is backup content.
For Dr. Akash, for your previous point, I would like to add one thing. It is
Sorry
better
to
to have your
interrupt,
own analyzers in your hand, in your lab, like whether it's CO2 analyzer. That is now one of the most important, which decides, like it is not that sometimes in the rural place or somewhere that it is not easily the technician or the people who are doing MC or calibration are not available. So to even if you find any changes, is that CO2 percentage is very important factor which decides actually our troubleshooting, the future of troubleshooting. From there we start thinking. So one good thermometer and one CO2 analyzer is must for
These are
any
minimum.
IVF lab.
These are
Sorry to
it's a minimum.
interrupt.
Yes.
Sorry,
Manu.
interesting discussion, but we are running out of time. Could you please?
So
Yeah,
we'll wind up in next
Thank you.
couple of
Thank you so
minutes.
much.
Witnessing protocol compulsory for electronic, yes or no? We'll just take a quick vote for each of the.
Yes.
No.
Yes.
No.
Yes.
How many
Not
for yes?
compulsory. Not
See,
compulsory.
manual mandatory.
Witnessing is
Not
compulsory, either electronic or manual.
Yeah.
That is depending upon
Double
the budget of
witnessing
a
is
center.
compulsory, Ram. Agreed, 100.
Yeah.
Electronic witnessing.
Electronic witnessing is not compulsory.
Not
Please
If your
compulsory.
budget
not
allows,
compulsory.
yes.
Not
If your
compulsory.
No,
budget allows.
compulsory. We are talking about compulsory by law. We are we
No,
telling like
not
that?
by law. Not by law.
Okay.
According to you. Not by law.
Okay,
According to you.
necessary. You mean like
Yeah,
rather than
necessary. Like you said, CO2
Definitely.
analyzer is also not necessary by law.
No, but it is one of the
Essential,
not mandatory, but essential. So like that. So if some like if you ask me if you would you like to have that, yes, definitely we'll go for yes. Yeah.
Essential, yes.
Yes.
Sanket, Dayanidhi.
I think it depends on number of cases also.
Yeah.
So if you are, number of cases are more, I think it's mandatory because that will give you zero mix-up.
Not essential. Depends on the workflow you want to say.
Definitely. See,
Yeah.
See, each and every
We'll
equipment
go into
has
the next
also a
question,
power.
Dayanidhi. I understand you
Yeah.
have your
But
right reasons.
But yeah, I think we need manual is mandatory, and then this is optional depending on your usage, depending on number of cases you can decide.
Sanket?
Yeah, I would like to add just a couple of points to that. What happens is, first of all, we're discussing about is it compulsory or not. First, let us understand, even with electronic voting system, things will go wrong. Because
Exactly.
labeling at the time of entering, I mean, when you make the tax, if you're not concentrated and there is no second person to witness that, to confirm that, the first step, if it goes wrong, it's a snowball effect. Everything goes wrong, right? Number one. Number two, I think you should have electronic plus manual all the time.
So
manual is a
compulsory.
mandatory. Yeah.
Manual is mandatory irrespective of it. That I think all of us agree. Preferably essential where possible. Daily quality control, which is a more technical part of it, will not go. A quick word about backup utilities, and then we'll go on to the last one. Finish this in 1 minute.
I think
What backup
I think we have the backup of DGs would be there. Then we have I just forgot the name. Backup of UPS. UPS should be there.
You should have at least a double power backup.
Yeah, UPS is mandatory. UPS and then followed by the DG backup is very essential for the laboratory. And still the gas and all that anyway is part of that. That you have to have the backup of gas cylinders and other thing. More than that, I think for each for the microscope also you need to have certain accessory which is very urgent if it is required, like microscope bulb or some that all are very essential, I think.
Basically require a backup where possible duplication of things. But remember, compulsorily to have one is incubator is made mandatory in the law, where it is compulsory you have 2 incubators, and things which require continuous supply. One is your power and one is your medical gases, where you should have in double backup at least. Yeah, Sanket, you want to add in?
Yeah, I think most important what people
and people as a backup. Yeah.
No. The thing
Yeah.
is what
Yes.
miss out is everything is a backup. Say it is incubator or microscope or any other equipment. But people generally don't have backup for suction pump. See, at the time of OPU, if you're doing OPU and if the machine is gone, then just imagine on the table, you can't do anything. The cycle is wasted. So I think I think better to have a suction pump as a backup.
Yeah, a good choice to have as a backup. Good choice as a backup.
As essential equipment has to be taken separate consideration, and they can be kept as a backup. You can purchase 2, as we were discussing about liquid nitrogen containers also, like all those equipments has to be there in the backup. Water, electricity, and as what Dr. Akash has mentioned, the people, means an embryologist or a gynecologist, means they are stuck somewhere or they are not available on the day of procedure. At least one should be there to perform the procedure, and they can perform it easily and well in a well coordinated manner.
And they should be registered as well with the same clinic.
Yeah,
just
with
like
the
similar to
same clinic,
PCP and
they
DP.
should be registered. Yes.
Last question. And
Question.
I'd like to take each one's view, cost and timeline to set up a good IVF lab, nothing over the top, something which you consider essential. We'll start each one's. Start with Sanket, then go to Dayanidhi, Sanjay, Ram, Rahul.
Realistic cost in the sense including the non-sterile area, which is OPD area, everything, right?
Yeah, everything. Suppose who wants to start IVF lab standalone.
I think
IVF.
somewhere between it, I think basic looking at the rates nowadays, I think 1.5 CR is bare minimum what we got to invest, because your lab and OT itself will consume at least 60 lakhs, 60, 70 lakhs, right?
Okay.
So apart from that, other expenses, ancillary expenses will be there, overheads will be there. So I think 1.5 to somewhere between 3.
1.5 to 3 and timeline, other than the regulatory requirements of recognition by ART board, timeline.
I mean, I think again, it depends on how big your clinic is. Suppose say
roughly, that's right.
Timeline
Someone
says
wants to start.
Complete. See, procurement of the moment you order lab equipments, for the procurement will take 45 days minimum, right? So
Right.
I think it should be between
Licensing and all, everything like the permission
Hmm.
takes 2 to 3 months.
6 months to 1 year, six months to 1 year.
Yeah.
Anyone else?
3 months.
I think
Dayanidhi.
if you're going for very
think
basic, sorry,
Yeah, Ram,
Dayanidhi,
please go
please
ahead.
go.
Yeah, So I think it starts with 1.5 CR till 3.5, excluding the PCPNT machine or ultrasound machine, because that is not part of this. I'm talking about the IVF lab. And the time would be minimum 3 months, excluding the licensing part, because licensing part again depends on how easily you get from the government. So that I'm not included, but yeah, 3 months minimum you need to give for the entire setup.
Okay, Ram.
I think if you are constructing a very basic lab, minimum is 1.5 CR with 4 to 5 months of time, including construction. If you are trying to build a mid-level or good lab, it will go somewhere around 2 to 2.5 with good quality equipment, with good quality of construction material. Time is around 5 months again. And if you are planning for a high-end lab with very good quality of equipment, with a lot of add-ons and with good materials like fully modular lab, fully modular OT, then the cost will be somewhere around 3 to 3.25 with 6 to 8 months of time frame.
Yeah.
That's what my personal experience as well. I have constructed all kind of labs.
Right.
And this is my personal experiences, like minimum, of course, the person who takes contract will promise you for 3 months, but trust me, 3 months are nothing. You will only see walls. You will not be able to see the complete setup. AHUs and everything will take time. At least 6 to 8 months you have to give if you are constructing a very good IVF lab.
Yeah,
I
true
agree
that.
with this. Six months is, I would say, realistic. 4 months would be ideal. 3 to 4 months would be
So
ideal.
why I said 3 months, because we have done many setups in the Bihar also. So definitely 4 to 6 months. And I'm talking about the entire IVF, not IVF lab, the entire IVF setup, starting from the
Danny,
4 to 6 months. Yeah,
that's a chain of clinic which is already well versed with setting up labs versus a person who enters newly. I would say 6 months is the time which they should be looking at.
True.
Yes.
Okay. So I think we'll close with that because we are running short of time. So thank you so much. And I hope we all had a good time and the delegates had a good time attending as well, those who have attended, and it answered quite a few questions of them in terms of lab setup. We have seen how equipments are probably the most important, the core of a IVF lab setup, but they constitute only a part. It's your regulatory compulsions, mandatory parts which you have to fulfill, the personnel who have to be there, that's the more variable part, backups that you have to take, the documentations that you have to do so that you don't end up in a mess. We are very enthusiastic at the start, but we need to be for the long run, not a short run. So with this, I thank all of you, my co-moderator, Dr. Atita and Dr. Kalpana as well. Yeah.
Thank you so much. Thank you. It was a wonderful discussion.
Thank you, Akash. Yes, thank you, Atika.
Thanks, Ram.
Thank you, everybody.
I like that you're in the dark background, how we embryologists usually work. In the dark.
Thank you so much. Thank you, Dr. Akash and Dr. Aditi.
Back end, many a times they are counseling the patients, giving the information about the embryos, and they play a key role. They're not in the dark end, Dr. Akash. So it was really a wonderful panel discussion. I really enjoyed it, Dr. Akash and Dr. Aditya. And all other experts. And even your wonderful views. Thank you so much.
Thank you, ma'am.
Thank you.
Radhika for coordinating this event successfully. Your final words, Radhika.
Yes, ma'am. I thank Dr. Kalpana ma'am for giving me the opportunity. And I thank Shanta Devi ma'am, the secretary of MCOT, Dr. Jayesh Amin, who's the president and the chief guest, and Dr. Sampath ma'am, who's the past vice president Foxy and guest of honor. I thank the first panel members, Dr. Mani Mukta, Dr. Sadhana, Dr. Swarupa, Dr. Kushbu, and Dr. Vandana, Dr. Indu Chauhan ma'am, and Dr. Kriti Prasad, who did a wonderful discussion on ovulation induction. And the second panel, very interesting, setting up of an IRT lab. Thank you so much, all the embryologists, Dr. Atita Shinde and Dr. Akash Agarwal, expert Dr. Rahul Sen, Dr. Sanket Dumal, Dr. Sanjay Yatnale, and Dr. Dayanidhi Sharma, Dr. Ram Prakash, Dr. Falguni Patro, and Dr. Parag Nandi. Very wonderful discussion, and we all benefited. We are all benefited, and hope hopefully delegates find this wonderful. And it's the fragrance from Blossom. Thank you so much. Thank you. We'll meet in the next session. Thank you, Kalpana ma'am.
Thank you.
Thank you. Thank you.
Thank you.